presenting my talk on artificial intelligence and gynecological malignancy perspective of a clinical oncologist. So this was a review article that was done by my co-authors, Dr. Ruchika Goel, as well as my mentor, Dr. Piyush Kumar. So yeah, I'll be covering the topic under the following headings, that is AI in screening and diagnosis, the use of AI in radiotherapy, its application in surgery, chemotherapy, in research and follow-up, and challenges, and what are the future directions. So first, just knowing what actually is the global burden of gynecological malignancy. So as we all know, with the recent Globocan, that gynecological cancers, they account for 19% of the global cancer burden, and the most common amongst them is the cervix, accounting for 6.5%, followed by ovary, and followed by endometrium. So definitely, yes, it requires a multidisciplinary treatment approach. So, what are the common types and treatment overview for cervix? We all know that early stages can be cured by surgery or radiotherapy, and in the advanced stages, we need a combination of radiotherapy as well as chemotherapy. Ovary surgery remains the mainstay, followed by the chemotherapy or neoadjuvant chemo, followed by surgery, depending upon the case. And radiotherapy has a very minimal role to play. When we talk about endometrium, surgery plus adjuvant radiotherapy, if advanced cases, is required. Now, all the things are changing according to the molecular markers, as we all are aware of. So, what artificial intelligence can do in this medicine part is that AI simulates a lot of neural networks for data interpretation. It enables evidence-based, bias-free clinical decision-making and increasing vital oncology workflow. Like in endometrium, we know that we need a lot of molecular study. So with the use of AI, we can do it fast rather than waiting for a week or 10 days for the reports to generate. We can do it fast and we can know the prognosis better. So why AI matters in oncology? Because it handles large multifactorial data. It enhances diagnostic accuracy and reproducibility. It supports clinician planning and follow-up. So when we talk about AI in cervical cancer screening, so what it does is it has deep learning model that analyzes the pap smear with high accuracy. It detects subtle abnormalities that is missed by manual review and reduces false negative and improves the thought process and the output. So AI in colposcopy and biopsy, it identifies suspicious cervical regions for biopsy. It optimizes site selection, minimizing false negative, and improves the diagnostic confidence and efficiency. So chances of miss, chances of having an inadequate specimen will not be there. So AI in ovarian endometrial detection, there are some CNN's interpretation ultrasound, MRI and CT data, which predict the malignancy risk using clinical and histological data and enables earlier detection and targeted intervention. But again, AI has its own limitations that it depends on large, well-labeled datasets, high computational cost for deployment, and requires validation across the population. Now, talking about the radiotherapy workflow, so there's a lot of steps which are involved in radiotherapy, like planning, imaging, contouring, dose prescription, etc. Then, when you have to execute, you have to verify the this patient position, then treatment delivery and quality assurance. So, with the use of AI, this hectic schedule can be realigned. How? AI in image acquisition and fusion. It generates synthetic CT from MRI for planning, reduces the CT dose and registration errors, and enhances the image quality and safety. AI in contouring and dose optimization. It automates the target and organ delineation, personalizes dose based on prior plans and outcomes, and it saves time and increases the consistency. Now, AI in plan verification and QA, it detects the setup errors using CBCT image enhancement, predicts the machine faults like collimation errors, and improves the treatment accuracy and patient safety. Now, AI in gynecological surgery. So it integrates imaging from pre-operative mapping, guides robotic and minimally invasive surgery, which enhance the precision and there's a shorter recovery period. So AI and 3D imaging in surgery. Now we have 3D printed pelvic models that assist preoperative planning, augmented reality that overlays show tumor organ relations and reduce the intraoperative complications. So further to add is virtual reality simulators improve the training performance. It enables repetitive feedback driven practice and reduces the learning curve and human error. So how now it helps in chemotherapy is it is a sort of personalized tool. Like AI integrates genomic and clinical data for regimen selection, which we often do by a hit and trial. So it minimizes the toxicity because it is patient based. It will analyze the comorbidity data of the patient and now it will choose the best regimen. So it is minimizing the toxicity as well as maximizing the response. And it supports the individualized patient management. So now how predictive modeling of response is there. Machine learning predicts therapy effectiveness, identify patients likely to respond or experience toxicity, aids proactive treatment modification. AI in treatment monitoring, it analyzes the patient data in real time during chemotherapy, early detection of adverse effects, enables timely intervention and dose adjustment. So AI in research and protocol development, it analyzes the outcome, recurrence, metastasis, survival, builds predictive models for protocol optimization and accelerates clinical trials analytics. Data-driven personalization, AI refines treatment guidelines using real-world data, bridges the gap between evidence and practice, and improves the long-term survival and quality of life. So there are challenges and ethical concerns, that is data privacy and consent issues, responsibility in a case of AI errors, need for interpretability and transparency. Implementation barriers. There's a lot of financial costs involved and need for technical expertise, limited regulatory framework, bias and generalizability issues in training data. So finally, to conclude, AI is revolutionizing gynecology in gynecologic oncology, requires regulation and ethical oversight, and should complement, not replace, the clinical judgment. Thank you.
I would like to share you a quality improvement project. It's about improving early initiation of breastfeeding through integrated OBD, labor ward, and postpartum period. It was in 2024. It's done by me, Dr. Fatima Babikir, and Dr. Bari Al-Haj. So the project was led by multidisciplinary team. Actually, the OB/GYN team is a leader one, involving the head department, and we have the nurse staff in L&D, OBD, and in postpartum. We're hiring new nurse that is was responsible from this project. So neonatology department involved, and the head nurse in L&D, OBD, and OR, and there is the data analysis from the HR. Regarding the our quality improving project, so we know that early initiation of breastfeeding is the one of the most important things to both babies and mothers, that establish a strong relationship between the mothers and their infant, provide them essential nutrition and immunity for the baby, and of course reduce neonatal morbidity. And they found that even improve the IQ for the newborn by doing this as early as possible. Skin to skin contact also very important, that make the baby feel comfort, the mother as well, and it is help a lot in the baby that born with transient kidney of newborn, and this is leading to less admission to the neonatal ICU by just skin to skin contact. They found it reached up to 90%. So regarding delay card clamping is also important. We did delay it until 3 minutes successfully. It was comfortable to the patient and to the staff, and this do not that improve in the neonatal outcome and decrease also the neonatal ICU admission. So our objective was increase early breastfeeding and improving skin-to-skin contact, delay cord clamping, and to address the issue identified in the basal assessment. So we did the basal assessment by bonefish, and we use also BDSX cycle, 24 plan, implement, assess, and refine intervention that collected in multiple portions during the months of 2024. So cycle one, it was plan doing, it was in January, February. The plan was identify barriers that need for staff training. We found that we have lack of the training when we perform this project. So we did train, we sent the nurses and doctors outside our hospital to have training for 2 weeks. We did health education, also training, a follow-up of the protocols that have been put since 2020 2015, and we implement now strongly. We prepare training session and educational materials for all staff in the OBDs, labor ward, postpartum wards, and operation theater. Regarding do contact initial staff training in January 25 done, 24 done. Begin health education from mother during antenatal visits. It starts from the early as 2024. There was baseline data early initiation less than 20 to 20 to 40. It is the highest percentage in 2023. It was 40%. So we emphasize staff awareness and protocol implementation. In the cycle two, explain education and follow-up system done, engage leadership to support the ongoing intervention. Where we found that there is a problem in the leader, we did train for nurse and doctor, and we make them to lead the project. We implement follow-up procedures in OBD and postpartum wards, reinforce training. Data show improvement from January by 80% and May 92%. Observation, a steady increase observed. So continue education and improvement follow-up process. This was our plan. Address field cycle 3, address the barrier, optimize protocol, monitor adherence. We did additional staff. There were we and hiring the new nurse that we found that we need a new nurse that will be 24-hour covering the L&D, responsible to do skin-to-skin contact and to supervising the whole project. So we find that from January was 80, May 92, and even in August it was highest until 91. We are focusing on sustaining gain and addressing barriers to full compliance. We have barrier in the operating theater that much of females, they refuse to do skin-to-skin contact in the operative theater. So in fourth cycle by November, we did the final review and sustainability plan. We did intensity training and follow-up system, feedback, and continuous monitoring. The result of January was 80, May 92, December is up to 94%. Overall, it's increased approximately by 90%. So we start with 20. When we reached December, it was almost 90%. So plan for ongoing sustainment and scaling. So let's see what's the final result by diagram. If you note here in January 2022, we find that is 20% almost. Then in 2021 is also, it is not different the same. And when we reach the 2024, we find this is very high now. It is up to 80% in January. So this is our diagram to show how much is this from January 2022, 2020 until 2025. Now, when one in October, we reach up to 94 compliance skin-to-skin contact, delay cord clamping, and early initiation of breastfeeding, of course. So our achievement, it was significant improvement in early initiation from 20 up to 90% during 2024, enhanced staff awareness and protocol adherence, of course, better integration between the OPD, labor ward, and postpartum period, and even we did virtual clinic. In postpartum period, we'll follow up to 3 months postpartum to confirm that they are still doing breastfeeding at home. Challenges, of course, and lesson, maintaining staff engagement, it was our difficulties. So we need more staff training and in hiring more staff in the labor ward and in OPD clinic. We open a new clinic, virtual, and clinic in our OPD regular attendance during the antenatal visit. The operative theater, as I mentioned before, many women, they refuse to do skin-to-skin contact as there's many male doctors and they feel uncomfortable. So we decide to do this in much more privacy. Ensuring follow-up and continuity. Some women, they were not answering the follow-up during the virtual clinic, so we lost some data in follow-up. In infrastructure and resources, we have a problem that where in the neonatal department, there was someone brought a lot of gift to the mothers, including the gift of formula. So we stopped this and we replaced it with encouraging them to do breastfeeding naturally. Our conclusion that we have successful implementation of VDSA cycles in 2024. We achieved measurable improvement, and it has been appreciated by our local program of KIBs and emphasize ongoing quality of art, of course. So we need in the future to continue monitoring long-term sustainment, expand to the other areas. We are planning to implement this change in other hospitals around us. Ongoing staff training and patient education, of course. Thank you. Any question?
Thank you, Dr. Fatima, for your
everyone. I am Dr. Rose Iwama, an obstetrician gynecologist at the River State University Teaching Hospital, Port Harcourt, Nigeria. Today I'm going to talk about the trend of higher order multiple gestations in a tertiary hospital in South Nigeria. Higher order multiple gestations are pregnancies with 3 or more fetuses within the uterus at the same time. It is a rare occurrence with an incidence of 0.07% worldwide. Usually, 96.9% to 98% of all human pregnancies are singletons. In other words, singleton pregnancy is the normal form of pregnancy. But 2.2% are multiple pregnancies, that is twins, triplets, quadruplets, quintuplets, etc. Nigeria is noted for having the highest number of twins in the world, notably Igbo Ora in Oyo State of Nigeria. Dietary factors have been associated with these findings. It has been hypothesized that certain plants in western Nigeria contain hormone-like compounds that raise follicle-stimulating hormone levels. As a result, boost the population rate of dizygotic twinning and superovulation. Higher order multiple pregnancies are due to superovulation and not cleavage of zygotes. There are predisposing factors that can lead to higher order multiple pregnancies. But because of insufficient number of naturally occurring higher order multiple pregnancies, studies have only compared twins and singletons. The predisposing factors include parity. It has been noted that multiparous women are predisposed to having higher order multiple gestations. Maternal age is also a factor. Women that are 30 years and above are predisposed to having higher order multiple gestations than women that are in their younger reproductive ages. Race is also a factor. The blacks have been found to have more prevalence of higher order multiple gestations. Family history. It can also run in a family where most of the women have higher order multiple pregnancies. Nutritional factor is also a predisposing factor. As I mentioned earlier, there are plants that can increase the secretion of hormone follicle stimulating hormone and thus predispose the women to higher order multiple gestations. Body mass index is also a factor. Women that have body mass index 30 and above are more predisposed to having higher order multiple gestation. Assisted reproductive technology is a major factor when it comes to higher order multiple gestations. A 5-year retrospective study done by Iwama Rose et al. At the River State University Teaching Hospital showed the high prevalence of higher order, a trend in the occurrence of higher order multiple gestation. Table 1 is showing the deliveries that occurred between 2019 to 2023 in our hospital. A total delivery was 9,538 that took place within this study period. Singletons were 96.87% as expected. Twins were 290, that's 3.04%. Triplets were 33, 0.35%. Quadruplets 4, 0.04%. Quintuplets 1, 0.01%. The prevalence of higher order multiple pregnancy from this study was 0.39% or 3.9 per 1,000 deliveries. A similar study done in 2021 by Origi PC et al. Had a prevalence of 3.5 per 1,000 deliveries. Both of these studies were done in Nigeria. An earlier study in Nigeria also, Patricia Akintan 2017, noted a prevalence of 0.75%. As in other low and middle income countries, there was an initial reluctance to approve and practice assisted reproductive technology. This delay in approval was because of inadequate infrastructure, high cost implications, epileptic power supply, some cultural and religious beliefs that multiple births were abnormal and should not be accepted. But over time, assisted reproductive technology has gained ground in Nigeria. In this study, 79% of the study participants had their conception by assisted reproductive technology. Only 21% had natural spontaneous conception. Figure 1 is showing the mode of conception. Figure 2, the mode of delivery. Cesarean section was the mode of delivery for 95% of these women. Only 5% had vaginal delivery. Table 2 is showing the socio-demographic characteristics of women of the study population. Highest occurrence of higher order multiple pregnancy was found in women above 40 years, that is 42.12%. The mean age was 37.5%. Nulliparous women were highest, 44.74%. This was because they utilized assisted reproductive technology as mode of conception the most, having had failed attempts at natural conception. Educational status. 50% of the women had tertiary level of education. Thus, there was an increased awareness of motivation to use assisted reproductive technology. Table 3 is showing the complications, maternal and perinatal complications of higher order multiple pregnancies. From this table, we see that anemia was the highest complication. Most of the women were anemic, preeclampsia, severe preeclampsia, placenta previa, preterm pre-labor rupture of membranes, and hyperemesis gravidarum, especially in the first trimester of pregnancy. Some women had more than one complication. That is why in the percentage column, you see that it's not tallying to be 100%. The commonest complication was anemia, 84.21%. Also, preterm pre-labor rupture of membranes, 84.21%. Perinatal complications. The number of children delivered within this study period that had from higher order multiple gestations were 120. Preterm births, 92.12% of them had preterm births. Low birth weight, 91.66%. Respiratory distress syndrome, 90%. Perinatal deaths, 11, that is 9.16%. So the neonatal characteristics, that's table 5, is showing neonatal characteristics. The number of women that had triplets were 33, number of babies 99. The gestational age at delivery was 33 to 37 weeks. Live births were 95, perinatal deaths 4, and the average birth weight was 1.9 to 2 kg. Quadruplets 4, number of babies 16, gestational age at delivery was 32 to 34 weeks, and the live births were 14, perinatal deaths 2, and then the average birth weight was 1.5 to 1.9 kilogram. The quintuplet was just one woman that had quintuplet. She had it at 26 weeks gestation. All of them were alive, 5 of them, but within 48 hours, all of them had perinatal death. From this study, the increasing trend of higher order multiple pregnancies was as a result of increasing acceptance of assisted reproductive technology as a mode of conception. In countries where assisted reproductive technology is regulated, maximum number of fetuses implanted during in vitro fertilization is 2. In Nigeria, where there is no regulatory body yet, doctors implant more than 2 zygotes. Women who, due to career pursuits and socio-political ambitions, have delay in starting their families may later become desperate for conception and childbearing. They are willing to carry as many fertilized eggs as possible during one pregnancy. In conclusion, there is an upward trend of higher order multiple pregnancies due to assisted reproductive technology and advanced maternal age at conception. In order to reduce maternal and perinatal complications of higher order multiple pregnancies, women need to be educated about the implications of implanting more than 2 zygotes during in vitro fertilization. As we can see from the previous slides, a lot of complications are associated with higher order multiple gestations. Regular antenatal visits and proper antenatal care is important for women having multiple pregnancies in order to have successful outcomes. My references are these. Finished. Thank you.